First thing I would like to do is acknowledge the traditional owners and custodians of the land on which we meet today, and pay my respects to elders past, present and emerging, and also to extend that respect to other Aboriginal and Torres Strait Islanders who are joining us either here or online today. It is with great pleasure that I'd like to introduce our speaker for this afternoon. Dr. Jan Melichar and I first met back in 1998, I think, where we both had the good fortune to work for Professor David Nutt in the Psychopharmacology unit of the University of Bristol. Jan and I were at that stage both registrars in psychiatry and clinical researchers. And Jan was doing some elegant imaging work looking at methadone in the brain and pharmacokinetics and PET imaging of opiates and other aspects of psychopharmacology, also including anxiety disorders and antidepressants as well. We've asked him to talk this afternoon specifically about his experiences of UK drug and alcohol treatment models, because I'm aware that things have gone very differently since I left. People used to say, "Why are you leaving?" And I said, "To beat the rush." So hopefully we can use this as a way to try and persuade Jan that Australia has some excellent opportunities for practising addiction psychiatrists. But we've asked him here specifically to talk about really his experiences in the last 10 years and longer of addiction psychiatry in the UK, and a list of things not to do in Australia. So please welcome Jan Melichar.
Thank you for that introduction, Mark. Tricky. How do I top that? Yes, I've been in addiction psychiatry in the UK now for 27 years. That's really terrifying. When I started, it would take up to 2 years to get onto a methadone prescription. And at the high point we reached, you could get onto a methadone or buprenorphine prescription on that day if you turned up sober enough, as it were. And now we're heading back to the past. And yes, there is going to be a rush, strangely and sadly. Let me see if I can help you with some of the lessons learned. I mean, the lessons are basically don't involve politicians, but you have to. And so sometimes you can go, well, what are the levers that work for politicians? And I'd summarize that by saying, not science. We have the Daily Mail. I'm sure you have a similar newspaper that peddles Donald Trump's fake news. Whatever floats the Daily Mail. So hopefully you'll see that here. Now this is obviously my reflection on it, and I'm sure it would be very differently viewed by any politicians in the UK, and they'd say, no, it's all efficiency savings rather than cuts and cutting things, so you're losing limbs rather than fat. Whenever I hear the words efficiency saving from UK politicians, it's just sort of, it's like the magic money tree. It's painful to hear. Anyway, so what happened to the UK drug treatment system? This is sort of my personal view over the long time. I've been in that system and have left. I was very simple. Until 2015, I could quite happily call myself a sort of clinical academic heading forward into the future. I was a clinical senior lecturer in psychopharmacology, predominantly substance misuse, but anxiety, depression, complex pain, taste, at the University of Bristol. And I was a consultant in substance misuse. We had a big NHS service. I'd set up and sorted the inpatient unit. We were doing novel and interesting detox things. There was lots going on, and then the wheels came off. So I'll talk to you about lots going on. I'll talk to you about the wheels coming off, and we'll see where we go. Since leaving, I do quite a lot of stuff. So I've gone from a very sensible, plain vanilla clinical senior lecturer and consultant in substance misuse And now I'm a medical director in one of the charities that is involved in substance misuse and pain treatments. I'm a consultant psychopharmacologist, sadly in the private sector, because the NHS shut the psychopharmacology clinic down because they said you don't need specialists to see people with anxiety and depression and look at their medications. It's just not important. And then a year later they said, oh, we shouldn't have shut that down. But never mind, we've learned lessons and we'll keep it shut. And incredible. And I'm a consultant psychiatrist in the, if you like, the NHS opiate analgesia dependency service. So where we see people with codeine and other issues which they've picked up and are absolutely clear they're not like these junkies, they have special dependency. And it's how to work with those. And that's really interesting. You know, if I summarize that, it's same skill set, but really tell them it's different. So you can wear your purple tabard for the methadone and buprenorphine clinic and your green tabard for the opiate analgesia dependency clinic, same person underneath. Okay, and this is what I morphed into. This is the joy of my daughter having to do her art. Okay, so I've tried to put it together. This isn't actually completely accurate in terms of the times, but it helps you understand how things geared up to get to a good service, which was, I would argue, world-class in terms of its approaches and how it was heading, how it evolved from getting people in, getting people abstinent, getting through to recovery, and then a big upheaval and the outcomes. And I'm hopeful that there's something in the future. So another way of looking at it is actually a journey through funding. Okay, so funding was very low, 18 million in 1982, and it increased in the peak in the sort of 2010s to 2012s to about $1 billion. It was enough. I'd say no doctor will say I've got definitely enough money, but honestly, it was good then. You could do things, you could adjust things, you weren't bound by too many strictures, you could try and evolve the service to what was needed. And then the rest of the story now is money has just fallen down. We've lost half the funding and it's going faster. Actually, is it 500 million? Probably not. There's a lot of false accounting or different accounting going on because it's spread across so many pots now. Okay, so before the millennium, harm reduction. The age before funding. This was in the 90s. If you were living in Leith in Edinburgh, it was the time of train spotting. Everyone was a criminal. Everyone was going to give your daughter HIV, especially if you were an MP. There was lots of worry about these scummy opiate addicts. That was the perception in the press at the time. Okay, and some of the people thinking about funding drug services used that. It was very successful until it came back to bite them later. So it was also the decade of the brain. I can't remember exactly how they phrased it, but imaging was going to solve it. The brain was going to be all sorted. And we're still here trying to figure out what's going on. But hey, it was useful because it gave us a thing saying addiction, definitely preventable, definitely treatable, changes biology. If untreated, it can last a lifetime. And here's some pretty pictures which don't really mean much because we don't understand the underpinning neurobiology. But hey, it shows it's, you know, one to the next to the other. I'm being slightly disingenuous, but I do have a colleague who is on the lab bench, and she always chastises me when I say, it's brilliant, look at this scan. And she goes, so what's going on there? Is it excitatory or inhibitory? And I go, it's shiny. So I say with a pinch, it has given us lots of insight, to be fair, and it has said, look, it's something that can be treated potentially. It's complicated, and sometimes the simple treatments you try, you realise need to evolve, and that's certainly what happened over the 10 to 15 years as the service had funding, and I hope I'll show you that. So then we had in the late 90s the National Treatment Outcome Research Study, which said basically if you treat people, whether residential on the left or community on the right, then they get better. Down at the bottom, darkest blue, is they're abstinent from all drugs, up to the lightest, which is they're still using opiates daily. And as you can see, there's a journey across to 5 years in they're using less. It's not as bad. It's not perfect. You know, these people have got to where they are in terms of their substance misuse for a variety of complicated reasons. They've been using, for some of them, for 10, 15, 20 years. They have no skill sets to do other stuff, but they're moving on to better on the journey to recovery. So taking that together, funding came. Now, the NHS wasn't going to give any funding to sodding junkies. They were very clear about that. They were clear that 18 million was enough for everyone. Thank you very much. But the Home Office, the people putting them in prison, thought, aha, this will work. And peddling fear about giving your daughter, if you're an MP, AIDS because you're sleeping around with a heroin junkie, even better still. And so the Home Office gave a shed load of money. So it's about the message was keep people alive, keep them out of prison, and don't give them HIV, or don't let them get HIV. So it's all about, if you like, harm minimization in a nutshell. And they evolved that to create the National Treatment Agency, which was, in terms of funding for the NHS, you had the Department of Health, health authorities, of which there are variable numbers, but call it about 10 spread across England, and they made an 11th one, the NTA, specifically responsible for all funding to the regions and the sub-regions for drugs, and then alcohol came later. So it had power, little bit of funding from the Department of Health, loads of funding from the Home Office. It was all about this, but the Home Office had lots of money. It was wonderful, the taps turned on. You could actually do something. And as I say, in the mid-90s, 2 years to get a methadone prescription, things picked up. So it moved to being successful. I'm alive, says this person. I'm not in prison. I'm HIV free. And this was actually a very positive thing, because before that there was literally nothing. It worked. You could say, you know, numbers in treatment went up, and the waiting times for the first time you got something went down. They didn't include, this is a slide deck that the Department of Health and the NTA produced in 2011. So they deliberately didn't produce any slides from before 2001 because the waiting times would have been way off. But it was fantastic. You know, I remember in the mid 2006, 2007, it was literally, if somebody turned up, I could whack them on methadone or buprenorphine pretty much the same day. That was great. I had the staff. There were, you know, a couple of consultants there. We had the inpatient unit. There were senior nurses, less experienced nurses, social workers, psychologists. There was a whole team. You know, it was lovely. You could feel like a proper consultant because you'd go, I've seen this person. What do they need and who can deliver that? And you actually had a choice and an ability to choose. So it's quite good. But then in the late 2000s, there was a feeling of we need to move on. We need to move on to an abstinence agenda. So the simple politician's view of moving things forward was, on the left, here is the client controlled by their brain predisposition. They're in the land of dependence. They climb this mountain of detoxification. It takes a week or two, and then they skip happily off into the land of recovery and drug-free. It's wonderful, all sorted. They might relapse, you know, but it doesn't really happen that much. Not really, but still, the Home Office was driving this agenda, so still keeping people alive, keeping people out of prison, controlling the bloodborne viruses, and adding an abstinence-based recovery agenda. Recovery started to almost become a political buzzword, and for a couple of years, everyone was arguing about it, and it felt like in Life of Brian, you know, there was the People's Party of Recovery and the Recovery Party's people, and no one could agree. You know, it just felt like, you know, it wasn't working. We needed to talk about recovery, but we don't know what it is. Because, is it worth spending this money for somebody who's alive, not in prison and HIV-free, but also on welfare? No functioning networks, no meaningful relationships, masses of other chronic illnesses, they're going to die in treatment. What's the point? You know, another way of looking at it is, yes, they were on methadone or buprenorphine, but they were also drinking their cheap cider, off to benefits agencies. We had Jeremy Kyle, we had a discussion before this webinar started trying to go for an equivalent. The American one was Jerry Springer. So they watch Jerry Springer, they don't do much with their lives. People are saying they must move on to recovery. And the argument was, for a year or three, is recovery just skipping off into the land of drug-free, and is it that's what we need to focus on? Ignore anything beforehand, it's all about that. And most doctors in the trade, most drugs workers who'd been around, were sort of scratching their heads because they were going, well, hang on, it's any movement, any progress forward is brilliant. It doesn't matter if it's 2 steps forward, 1 step back, it's just they're moving forward. And, you know, after a couple of years, it did evolve to people going, well, actually, first of all, let's be honest, there's a mountain of effort after the detox and after you've been in your land of dependence. And true recovery is anywhere along there, as long as you're moving sideways. You might fall back, but as long as you're moving sideways, backwards and forwards, that's recovery. And we were just getting to the stage of going, we're all trying to look at getting them in, getting them on something, getting them settled, unpacking all the other problems that got them on opiates in the first place, or other drugs, and moving them on. And this was the view, you know, can you get people? It takes time, but you can move them on, engage their personal responsibility, get them back in life and in work and in the 9-to-5 world. And in 2011, the NTA, National Treatment Agency, said, you know, we've done quite a lot. Now, because they were still home office focused, you know, a lot of their crowing was saying, you know, look at the money we've saved. 4 million, nearly 5 million offences prevented, £100 invested in drug treatment prevents a crime. And, you know, I have no idea how they got these figures. I mean, honestly, how do they know there were 100,000 fewer burglaries and robberies and that it saved 605 million? I've got the figure there, it must be true. But genuinely, there were savings. And, you know, as I said, numbers in treatment went up and away, and waiting times reduced. And the slide is gone wrong here, but 2% prevalence in people who inject drugs in the UK, 1% in Australia. We were both successes. Everywhere else was rubbish. Brilliant. See, I put the slide up for a reason. And they could crow about how many people weren't dying, because it was brilliant. The deaths had dropped off. They had wobbled a bit, but they had definitely dropped off, and they could draw a dotted line saying, you know, look at how many could have died if we kept on doing nothing. And that was great, 2011. And we had good guidance. There was an orange book, orange guidelines, which we called, which were about 140 pages long, printed out, handed out to everyone. And they were useful guidelines. You know, they said, for example, people needed to be in supervised consumption for at least 3 months, which helped commissioners say that's what you needed to do. And there were various really good documents coming out of, for example, the British Association for Psychopharmacology and nice guidelines, which were sensible. Alas, then we came to our dear Health Minister, Andrew Lansley, who is only the second crappest one. We currently have the crappest one. I wish I could mispronounce Jeremy's name here, but I'm going to be videoed and recorded, so Jeremy Hunt. Wow. The bloodbath of cuts then started. They called them efficiency savings, and they still do. It's been incredible to watch. This is where it sort of has gone really pear-shaped. There were massive reforms. One way of looking at these reforms is it was preparing the NHS for privatisation, sadly, because they had a massive influx of private healthcare firms from North America who'd already, as it were, pillaged South America and were looking to Europe and were using the UK as a breach into Europe, and were paying lots for the various ministers and MPs, sadly, to influence them. There was a massive revolving door through into these companies. And you went from a very simplistic thing, which is the Department of Health, 10 strategic health authorities, 152 primary care trusts, which basically settled out in the country, and the various health services paid, to then a transition where there were 4 merged strategic health authorities, 50 primary care trusts, 200 plus shadow clinical commissioning groups who didn't really know what they were doing, and the health services hoping. And then afterwards, it became 23 commissioning support units, 4 NHS England regional commissioning offices, 27 local area teams, 200 plus clinical commissioning groups, all commissioning the same thing with apparently freedom, but with very much locked down as to what you could do, and then the health services. So it became, this is how the funding happened. I tried to explain it, but I can't. It's complicated. There's various people that hold contracts, there's various people that commission, there's some local authority commissioning, there's some from Public Health England, some from NHS England, some directly from the clinical commissioning groups, a bit of Home Office money here, there and everywhere, some public health departments which are based in local authorities, so may have money ring-fenced but may not. And in the end, it all went very complicated because the NTA, if you remember, National Treatment Agency, that health authority separately set up for drug and alcohol services, was dismembered and shoved into Public Health England, and their senior people all left, and the money was notionally ring-fenced and is notionally still seen providing services. We don't see it. Some of it's gone into local authorities who don't give it out, and basically there's been cuts. The way to think about it is, yeah, at least 50 to 70% cuts. We moved into a 3-year commissioning cycle, so every 3 years you had to recommission and retender, and there ended up about 3 major players in the UK who were charities and then grew into, in effect, businesses tendering for these contracts, who had massive head offices to just focus on the tender and sweet talk the commissioners into them being the right people. And every time an NHS or local service lost a bid, they wouldn't be there in 3 years to bid again. So it ended up being these 3 services had most. A way of looking at that is there used to be 14 consultants in substance misuse in the southwest of England, okay, which would attend our quarterly meetings, and now there are 2 left. Everyone else is gone. Okay, that's not that the services have vanished; they've just been recommissioned elsewhere and de-skilled. So it's gone from having senior nurses, having less senior, having psychologists, to mainly having volunteers. The services are run by volunteers who have had lived experience. So that's like the orthopaedic department being run by people with broken legs. Brilliant. Actually, it works to an extent, but not to a clinically commissioned extent. So what's happened? Well, the money is falling, and in Bristol, for example, that shiny new ward that I opened in 2006 is now being shut. It's the last NHS ward that was left in the southwest and Wales, and now it's going. staff are leaving, and in fact, it's the outcomes are, for example, remember that slide about projected deaths? Yeah, it's gone up. If I go backwards, look, see if you can spot. When the funding came. Really tragic, because actually it's a bit like the sea. It follows, but there's a 2 to 3 year lag before you pick up the deaths, and it's really happening now. It's you'll be pleased to know, Mark, Scotland is up there. It's #1 in Europe in terms of opiate-related deaths. It's run up there fast. Even though Leith is now totally gentrified, other areas of Scotland are taking up the slack, sadly. And in Bristol, dear Bristol, they put a tender up just now, a bit waffly here, I apologise for that. They said they were going to spend 8 million on substance misuse. Now, it was about 13 or 14 million in 2010-11. I can't remember the exact number, but it's gone. And this 8 million was a cut from about 11 million previously. That's a big cut. And they were going to cut more anyway as well. But as the CEO of Collective Voice said, the only way to put a floor in the market is not to bid. And that person, Paul Hayes, used to be the NTA boss. So he used to run the Strategic Health Authority that ran substance misuse and then left when it was taken over by Public Health England. And to give you an example of just how bureaucratic things have become, I have a colleague who's a senior public health director in Bristol, and she used to be one level away from the head of Public Health England. Okay, following the 2012 reforms, there's now 6 layers of people between her and him, and she doesn't actually know what they do. She actually doesn't, she goes, well, I do public health here, he does the big policy, there's stuff. It costs money, but it's stuff. What happened in Bristol with all of this? No one's bid. So no one, last month, the tenders went in for starting in February 2018 for who's going to provide drug and alcohol services for Bristol, and for the big package of who does methadone and buprenorphine and detoxes and all that stuff. The local provider took a big step back because they were being asked for approximately 40% cuts, and none of the big players, no one stepped forward. And the commissioners are going, oh, and they've been doing that for about a month now. It's quite, if it wasn't so sad, it's quite funny because they're going, because they've got no money. I mean, they've got no money, and nobody's bid for the service, and they've got nowhere. They just don't know what to do. Good luck to them. And we've got a financial challenge. The NHS has got to magically save 30 billion. It's magical thinking because there's no way that can happen. So in the NHS, as I've been in it for the past 30 years, I've seen gradually, the fat being taken off, then the muscle being taken off, then the limbs being taken off, and now I have a torso and a head. There's nothing left.
Coming for your gonads.
They went long ago. It's not reproducible. And then bless the UK. It then had Brexit. I mean, my God, how to really get rid of anyone who wants to work for the NHS, because the NHS ran basically on Labour coming in from Europe. Europe and India and the Philippines, wherever they wanted to nick people, but a lot came from Europe because you could work in England for a while and then go back or stay in England, and it was run well. It was brilliant. And now I think this year they've had a 95% drop in applications from Europe for nursing posts, and I think, I wonder why. Can't imagine how not to do it. So 2017. We're back. Heroin is cheaper than it's ever been. The UK has more drug deaths than it's had for decades. As I said, Scotland is at the top level. Well done. We really shouldn't be here. In the mid-2000s, the UK was really cooking on gas. It really had an evolving, sensible system that was really doing good. And then, because we'd told the politicians it was all about HIV and stopping criminality, and that settled and became less of an issue, they lost interest, and it was easy to have the cuts. That's where it went wrong, I'd argue. And you know, you get bloatware. The Orange Guidelines went from 70 pages in the 90s to 140, as I said, in the mid-2000s, to 2017, a 320-page bloated thing that wasn't published. You could download it off the website and print it. Now, I actually went through it and generated a 20-page summary, which we call the Satsuma Guidelines. I have a friend to thank for that, but I like it. I'm going to work with that. Because there's some good evidence in there, good suggestions, but no guidance. There's none of this, you should do, you should have supervision for 3 months. It just says, well, you should consider supervision, it's a good idea. Like, yeah, but we're not going to really force you into anything because the commissioners don't want to commission services that would cost money. So we'll just give you some guidelines that have taken us 3 years to develop and are pretty vague. But we've sat as a committee and it's very good. Please read it, but we haven't got the money to publish it, so download it off our website, please. Which is really sad. The energy has left. But I think there is a new hope. All right? Yes, people are dying. Yes, tramadol and codeine is coming. GPs and hospitals will prescribe these medications if they haven't got anything else to prescribe for emotional anxiety and turmoil. It's going up the agenda. The newspapers are talking about it. There is no more HIV to scare the politicians with, but there are more deaths. There's more press coverage. And there are more, as it were, normal people on too much codeine and tramadol. And I'm old enough to have seen this 20-year funding cycle. It really feels like I really hope we've hit rock bottom. Okay, let's. It can't get further down than this, than nobody bidding for a service. I will have to wait for one more scandal to bring this government down and for the next one to come in. Okay, that will have to wait. Have to wait for Boris Johnson to drop his trousers or something. Who knows? It's not too much to ask. We don't have to wait long. Or David Davis to go back to Brussels. My God. Anyway, it will happen, I think. But if I had some advice for you, try not to sell the politicians a pup that will mature and then they can ignore it. So if they're going to fund services, give them a reason that keeps on giving. They don't listen to science, but they do listen to press coverage. So get the press on board. Keep them engaged. It's really sad to say that would be my experience. Or try to depoliticize it. Try to put it on something that it just happens. Thank you. Now I put this last slide up because I have just travelled across halfway around the world to talk to you. And do you know what? Caffeine's kept me here. So thank you very much.
I'm a pain physician. A lot of times the opioid starts with a person who thoughtlessly prescribes it in the first place, and a lot of the time that's in hospitals. Has the UK done anything to try and...
See, no, I would dispute that. I would say, yes, it happens thoughtlessly in hospital, but they haven't got any other choices, because I've worked in district general hospitals with the acute pain teams and so on, and looked and gone, actually you're up against a bizarre conflation of events. So you've got the surgeons and the orthopods running away from non-steroidals because they'll make the joints fall off or the guts explode if they even so much look at the non-steroidals, basically. And paracetamol will blow their livers up if they so much as look at it. And so they go, first line treatment, tramadol. Yes, I've been told by the rep it's fantastic, it's not an opiate. It's like some sort of noradrenaline and serotonin thingy, what's it, and not really an opiate. And it's filtered through the hospital network so that almost tramadol is the first drug, and then second line is another opiate. And then you've got a bizarre thing of primary care going, absolutely not, okay, but patients are released with 7 to 10 day prescriptions, and primary care will get the letter in 4 to 6 weeks. And these patients turn up. And I know my primary care GP colleagues go, but there's so much pressure in secondary care in the hospital to get them out the door for the next person coming into the bed, that the problem is, it would be lovely if we could stop that torrent. But I found in working as a in the opiate analgesia dependency side in primary care, actually it's getting the message into primary care, because you're not going to stop the junior doctors on the wards because the nurses will tell them to prescribe the sodding tramadol or they will bleep them at 3 in the morning.
I actually work as a GP in the community sometimes. Now, I think the issue regarding the opioid dependence with some of the patients that we're seeing is that, we start from simple analgesia going up to, the NSAIDs, the pain ladder pathway. However, what normally happens is that when the patient complains in pain, we would normally do an early referral, for example, to the pain clinic, but the waiting list is very long. And that's mostly, the frustration that we have, in the community. And so much so that we don't like our patients to actually be addicted to opioids, but at the end of the day, we don't have any other way because our patients need to function as well.
So the interesting thing there, what we found with our opiate analgesia dependency pilots, is two practical learning by experience things, which was we learned, and the GPs in the pilot learned, that chronic opiate prescribing was pointless because you could turn it on its head. These patients needed time to be engaged with to help turn it on its head, but they were coming in saying, I'm on 350 milligrams equivalent of morphine and my pain is 12 out of 10. And you go, sounds like it's not working. Now, you need to work through that resistance to change, and we'd end up going, let's have a trial of reducing some of it. Let's keep, what we found was actually part of the problem was that we were trying to stop the prescribing of the acute short-acting opiates and change it all into long-acting and reduce the long-actings slowly. And actually what the patients wanted was to have some backup for the emergency acute flare-up pain, if they had it, and they really couldn't give us stuff about the long-acting ones. So actually, once you'd had the discussion of saying, let's have a trial, if you're on 340 milligrams equivalent and the pain is still 12 out of 10, well, let's keep your acute morphines, but the long-acting, let's reduce them, and let's see what happens. And quite a few of them reduced. And then also what happened was the GPs learned to be upfront with patients in the acute stages, saying, these are great for acute pain. They're great as short, sharp shocks, but we know this is awful long term, so I'm just going to stop it after a few weeks. And because they set that agenda at the beginning, they stopped having the, but it helps my pain, as opposed to what the patients had actually learned, it stops my withdrawal symptoms.
And I mean, you talked about, you know, sort of methadone and opioid programs. So have you still got needle and syringe programs running in?
Yes, they're still just about going. They stutter, but they loaded them into the. So what they did was to even make it even more complex. Instead of having one funding stream for substance misuse in a local area, they said let's split it into three. The people that are engaging, needle exchange and engaging people on the street, the treatment, and the recovery service. Okay, recovery service run by volunteers, very cheap, very cheerful, or charities. Engagement, ditto, cheap, cheerful, because actually you're just trying to get people in, and you can have the needle exchanges based there. And the big service. So these in Bristol, I for simplicity's sake, I didn't allude to them. These had bids because they were small, self-contained, and didn't have massive cuts. This one didn't. So we've still got that, fortunately. So no HIV.
Yeah. Other questions? Yeah. Oh.
You had Riot a few years ago.
Oh,
how does that fit into the kind of current climate?
Badly. Oh, bless John. Dear Professor Strang. Really good idea if you have money and resources. It cost, because I had some prescribed, we inherited some heroin scripts when a clinic up in Gloucester shut. And we calculated it costs about £6,000 a year to prescribe methadone or buprenorphine, and it costs about £24,000 a year to prescribe the legal variant of heroin that we're allowed to prescribe, because it has to be freeze-dried in ampules, which is way more expensive than the best pure brown from Afghanistan. Way more. And so it's a lovely study, academically pure and super, which says, amazingly, if you offer people heroin who use heroin, they like using heroin. And there will be some that will be resistant to having methadone or buprenorphine if they have the opportunity of having heroin. It feels like a self-evident thing, but actually then you have to take a step back. You know, one of the reasons I sort of stepped aside from academia was because I got frustrated with the fact that you can prove verifiably something is really, 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 really true and have absolutely zero chance of it happening in the real world. And this is a perfect example. This is really true, really statistically significant, and really brilliant and completely pointless.
Yeah, it's a really good treatment that we can't afford and we're not going to get. Yeah.
Yeah, I mean, so, and all we'll hear is grief from people going, when's that coming? When's that coming? Let's focus on that. And you go, no chance, snowball, hell, think about it.
Yeah.
But it's very distracting. You know, it just sorry. It all comes down to bloody money.
Is there one, I mean, if I'm allowed to, do you think if we'd got one of your equivalent, you know, your opposite numbers in endocrinology or orthopedics or oncology or general adult psychiatry over here to give a similar talk, do you think they'd be giving us a different story? Do you think you've been
No.
Or everybody's feeling the same pain?
No, I'd say we're feeling more because we're at the vanguard. It's purely we're about 2 or 3 years in advance of everyone else because everyone else has much more of a voice. So if you look at money spent and representation and value for money or whatever, quality of life, etc., firstly, health gets, physical health stuff gets more than mental health stuff if you measure it sort of pound for pound or Australian dollar for Australian dollar compared to the misery, okay? And then when you disassemble mental health, substance misuse is way down there. And when you then have a system where you need to make cuts, you protect the heart attacks and the simple, easily measurable hip replacements, because you can always buy them from the private sector. You cut mental health, but you really savage substance misuse. Because these ones are easy to fix. These ones you can sort of skew, and these ones you can ignore. So these ones, you know, private hospitals are having fun doing hip replacements when the NHS hasn't got the capacity, and it just makes money. The private hospitals are fantastically happy. Mental health, the private hospitals are opening wards that were mothballed for all the mental health beds, because all the NHS ones are shut, but people are still being sectioned. And then you have the NHS bureaucrats making amazing sleight of hand. So there was a bit in the news saying there are no local mental health beds for children and adolescents. So if you're in Cornwall, you'd get sent to Gloucester, for example. Okay? But then what they did was say, but you know, that's in the same region, even though it's 300 miles away. So now they can say they went locally, because we've changed the definition of what is local as opposed to fixed it, which I love. And substance misuse, well, you just have these death statistics and they take 3 years to mature, so doesn't matter.
After the election. Okay.
So yes, the problem is we are at the vanguard, but everyone else is catching up.
All right, unless there's any last questions, I think I'll bring it to a close. Would you join me again then in thanking Jan for an excellent talk? Thank you.